and Richie is our last speaker for this afternoon, and she will tell us a little bit about using the EHR for PGX, and then also have some closing remarks for the conference.
Thank you. All right, let's see, is this mic working? Not yet, yes, hello? Okay, yeah, I'd rather not stand behind the podium. Good afternoon, everyone. We're almost done. I'm excited. So I decided, based on the rest of the sessions today, that I changed my title just a little bit. I added large language models with EHRs for this last talk of the day, primarily because I think we've heard a lot about electronic health records already throughout the conference and how they work and how they don't work. And I think that we're at a stage where large language models might be a technology that we can leverage to make our lives a little bit easier. And I'll talk about that in just a minute. So first, I thought I would just start summarizing some of what we've heard over the last 2 days. Lots of successes, but also lots about the barriers that we all continue to face. You know, one that I think is just both the blessing and the curse of pharmacogenetics is the prevalence of carrying pharmacogenetic variants that are important in populations. We've been looking in multiple data sets. So this was a study published by Sony Tutasia a couple years ago, looking in the VA. It was estimated that 98 to 99% of the veterans would carry actionable pharmacogenetic alleles. In the Penn Medicine Biobank, last year we looked out of, about 40,000 people with genetic data, 98.8% carry actionable pharmacogenetic alleles. A study led by Terry Klein's group and the PharmCat team looking at the UK Biobank, 100% of participants in the UK Biobank carry an actionable pharmacogenetic allele. So what does that tell us? So on the one hand, why are we not implementing this for everyone? Every single person in this room likely carries a variant that's important. So why are we not all tested, and why is it not in our medical record? Right? Call your senators. Go meet with your senators. Right, Christine? But the reason is because everybody has to be sequenced. Like, it's daunting. So it's not, let's just worry about our cardiology patients or our oncology patients or our really sick kids. It's every patient. And so I think for health systems, for insurance companies, it's just daunting to imagine. That said, the tests are not that expensive. I'm going to get into that in a minute. And there are lots of tests that we all get. Like, once you hit the age of 40, who's had a lipid panel? Like, every year. And I don't know what that costs, but the amount that these tests cost these days, I think it's a crime that we're not doing this, which gets me to the next one, is cost. So we've heard a lot. This has come up every time we've talked about barriers. It's either the cost of the test, the cost of the alternative treatment, reimbursement. It is, it isn't, it is in this state, it's not in that state, it is for this indication and not that one. There's a cost behind setting up the infrastructure. We just heard everything Laura talked about, like that wasn't free. Like, there's the machines, there's the manpower, person power, and then the alternative treatments. Again, you know, do you do a completely different course of therapy? But the other thing that I heard loud and clear is that we have to start, again, this is back to talking to our health system leaders, talking to our legislators about what is the cost of not doing the test at this point. I don't think we can continue to stand behind what's expensive, because it's expensive not to. So this is a screenshot from 2 years ago. If you had not heard, there was a lawsuit at OHSU, Oregon Health Sciences, for DPYD, not because they did a test and didn't use it, because they didn't do the test. And if they had done the test, perhaps this person wouldn't have passed away from toxic side effects from their chemotherapy. And this is a test that we've implemented here at Penn. Several other places have implemented it. So they actually sued and won. Or actually, I guess they settled out of court. But when you settle, it's because you think you're going to lose. So there are lawsuits here, right? So, I mean, if every patient who had an adverse drug reaction started to file lawsuits, like, is that what we need to get health systems and insurance companies to start to see? And then we heard Angela's story, which is the other one. So, you know, when you hear stories like what Paul shared with us, it's like, how can we not do this? Like, the talks were recorded. I did communicate with him and Juan Pan yesterday. we're going to separate his talk out and they're going to post it on Angela's website, but like I'm going to send it out at my institution. Like I feel like everyone who takes care of people in a health system should see, even if they only watch parts of it. But to me, it was just so impactful. So I don't think we can continue to say, well, it's expensive. I think we have to figure out how to make it happen. So the last one that we just had a session earlier about education, and I don't disagree. There is a lack of knowledge in our providers. It's some of our pharmacists don't know. Some do. All the ones in the room clearly do. But I've interacted. I go to ASHP probably every year, every other year, and give an educational talk. And I can't believe how many people come up to me at the end and say, oh my gosh, that was so good. I had no idea about this. I'm like, how do you not know about this? But depending where they train, they don't know about this. Our doctors, so I teach and Sony teaches here at Penn in our medical school education. Like we just started doing this in the last 4, 5 years. So all the doctors that trained here before, they weren't getting pharmacogenetics. They don't know what it is. The nurses, the APs, like it goes throughout. And then also all the decision makers. I mean, I will say here at Penn, our CEO is very supportive of precision medicine and pharmacogenetics. And he's like, Sony, Marilyn, go implement it. Do it. We're like, yes. And we have a few things implemented. But like we would love to turn on everything, but it's not as easy because while someone at the top might say go, there's a whole lot of layers between them and us. And it's the IT, it's the people that interact with the payers, it's the lab, there's just, as we've heard all week, there's just a lot of layers. So we've got to start to figure out, how do we get all of these education components? And we've been reading papers, we heard a session earlier, there's a lot of things we can do to try to do this. Continuing medical education is one, making videos and the trainings that you do, like annually people do their trainings, for their recertifications. But I think the electronic health record may be a technology, and especially if we can leverage large language models to try to close this education gap. Because there's just not enough of us. Like there's a lot in the room. I liked the show of hands earlier, like how many people were actually like trained in pharmacogenomics, and it's like a small number, but how many of us are teaching it, like who never got trained in it, more of us. There's not enough of us. Like we just can't go around the country and teach everyone. And we'd have to teach every year, right? Every year there's a new set of students and a new set of fellows and a new set of residents. So I think we need to start to figure out how can we leverage the electronic health record, which is the one thing that every provider touches interacting with patients. So at least on the provider front, and actually many patients now touch their EHR. You can make appointments, you order your refills, you message your doctor. Not all patients use it. I recognize there is a health equity issue. Not everyone has the technology skills or the data capability to do it. But for the ones that do, and certainly all of the providers are touching an electronic health record. And then the other is these large language models. ChatGPT is a big disruptor, and I'll talk about disruptors in just a few minutes. But this technology, while not yet perfect, and we're actually working on a paper right now about how imperfect they are for pharmacogenetics. One of my graduate students has been leading it along with 2 other graduate students, asking it all sorts of questions about pharmacogenetics and, what happens if I'm a star whatever and I get prescribed this medication, can I take it or not? And, some of the answers are like almost right. Sometimes it's like a little wrong. And sometimes it like just completely makes things up. Like we made up a star allele and it like went along with it. Oh yeah, that's a poor metabolizer. And then it was like, oh, well, what is the data to support this? And it's, what are the RSIDs that make up this star allele? And it printed out some RSIDs. And we Googled them. They're not actually in that gene at all. And then it said, well, is there literature to support this link? And it gave oh yes, here are the PubMed IDs. And they're not papers about that. They're papers, but not about this topic. So it's not there yet. But if you put the right knowledge behind the large language model, could the technology be used to do the types of queries and searches that we want it to? And I think the answer is yes. The reason that it's wrong partially is that it's doing text-based analysis, not numbers. So it doesn't do, like ChatGPT as it is, does not do great with digits and numbers. It's doing words. It's doing pattern matching of words. And so if you have, a CYP2C 9 star, put in other numbers. It's just looking for a pattern that's similar. And so if you make one up, it's like, oh yeah, that looks close enough. It's not close enough, but it doesn't know the difference. But if you put data behind it, so actual databases and knowledge bases like, I don't know, ClinPGx and PharmGKB and all that is going to be wrapped up in what we're now calling ClinPGx, can you use that technology along with it? And I think the answer is yes. So we've seen things, so I have a few screenshots, and thank you, Sony, for sharing slides. Just, I wanted some examples of, we've implemented. So it's not that the EHR cannot take structured data. So where's the pointer? Here we go. So we have a tab in our instance of Epic called PenChart. We put everything in the Precision Medicine tab, which is our implementation of the genomics module. So you can, click through and get kind of structured results. We can have the genotype and the phenotype kind of in the electronic health record. We have the ability to do inline warnings so that you can see actionable results. So here you can see kind of new warnings that have the ability to override, but warnings can be built in. Like, the technology's there to do these things. We also have integrated with external PGX labs, and you can see all of the genotyping that was done. So it's not a matter of, and we've seen this throughout several places have done this. That's not the hard part. If you do want to know how Penn did it, I don't want to spend too much time on that. This is the URL for our PenChart Genomics Initiative website that has both our pharmacogenetic and genomic medicine kind of implementation information. And if you're at an Epic site, there's even more stuff behind kind of the Epic App Orchard firewall. But this is a slide I borrowed from a colleague, Dr. Mitch Schnall, who's leading efforts in our health system. But the idea is, can we put something like a large language model in between patients and providers and the electronic health record? So instead of logging in the way we do now to MyChart or whatever you use, could you just say, Alexa, what medication should I go on for this? Or Alexa, I just got this test. It doesn't have to be Alexa. They'll probably call it Epic, or I don't know what they'll call it. And I have no stock in Epic or anything. It could be Cerner, yeah, right? I don't love or hate them. I just use it because I have to. But anyway, can we imagine a time where we can ask questions in kind of chat and like type way, in regular human language instead of BPAs and all these alerts and all these colors? Can we just ask questions? And then, I am diagnosed, patient diagnosed with this. I need to prescribe a statin. Which statin is most appropriate? And it could look in the database and look at the genetic data and say, given their pharmacogenetics, they should take this one. And just in human language, if you want to learn more, click out to something, but they don't want to know more. They don't have time. They just need to know and understand why. Why don't we use just regular language? And then similarly for patients, that we would be able to just ask questions of the EHR. So Epic is already starting to do this. If you go to their website, they are starting to implement AI in a number of different places. The main ones that you'll probably see first are going to be the patient experience, which we heard a little bit about, doing the kind of in-basket messaging responses, which are more empathetic and longer and kinder than an actual provider. And then I think we heard a little bit about the Reduce project, which I think Epic is doing similar things but with text, not all the audio and video. But what I think we should start to imagine is using these LLMs to enable the education of pharmacogenomics. So these are both images that I generated yesterday using openart.ai. So I asked it first, I guess I made this one first. Can you make a chat bot to interact with the electronic health record and discuss pharmacogenetics? And this one on the right is what it made. And I was like, oh, it's a chatbot. Okay. And then I said, can you actually make it a computer with an electronic health record and communicate pharmacogenetic information? And I thought it was really funny. It just put a bottle of pills next to the computer. But nonetheless, a couple ways that I think we're going to see this. So the electronic health record is one. The other is for the researchers and for all of us educating. I think we've been talking a lot amongst kind of the ClinPGx team about how do we leverage kind of these large language model technologies and chatbots and apps with what is being built in ClinPGx. both from kind of the easy to use, and we kind of saw some of what Michelle showed yesterday in the PharmGKB talk with their new app that is currently not using a large language model. That's just using kind of text. But imagine what she showed us and what everybody, or a whole bunch of us clicked on really quickly to use a large language model with it. And then you can also imagine leveraging those also for those of us doing research and development. Like, there's a whole lot of pharmacogenetic relationships we don't even know about yet. Like, they're probably in the database. They're probably in PharmGKB. And if we looked through all this variant data, there are probably patterns that we are missing. But with a large language model, maybe we could see them because it can read A's, C's, T's, and G's really well. Like, it's letters. So I think we should be leveraging that technology as well. So as I wrap up, I just want to mention ChatGPT is a big disruptor. And I think this is maybe the fourth one in my lifetime, one that I thought I'd mention. Because I think those of us who are like, this is a phase, I think it's not a phase. So this is meant to represent, oops, I don't want to go yet, the internet. So how many remember doing science before the internet? Look, young folks, we did science before we had the internet. We went to these places called libraries. We had to read papers like this. They were in journals. And we had to go to encyclopedias because we did not have Google. It was not a thing. I remember when the internet came out. I was in college. And I had professors saying, do your research paper. You may not use the internet. Which now is ridiculous. But now we have professors saying, you may not use ChatGPT. It's the same thing. It's a technology. We have to figure out how to use it. The other one, these are the microarray chips. So embarrassingly, my PhD thesis was on 25 SNPs. 25. That's all. I worked with Microsoft Excel files and text files. I was talking to one of my students the other day, like, wait, you didn't have a VCF? VCF didn't exist. It wasn't a thing. We had text files. When these arrays came out, we were all like, what? Nobody's going to do that. No, we now do it, and now we don't even use these. We're well beyond this. So the last thing are the Jetsons. This is a cartoon. So for the young folks, I know the people my age know this. For the young folks, this is a cartoon from the 1960s, but we watched it a lot in the 80s. They imagined things like robots that would vacuum and flat screen TVs and watches that we could watch shows or listen to music or talk on the phone, and reading the news on screens instead of black and white pieces of paper. This stuff that everybody thought was silly in the 60s, 70s, and 80s, we have all of those today. And so I would encourage all of you, as you hear all these AI talks and see all these AI things, like, really start to think about, like, how could we take these technologies and leverage them in the things we're doing? Because people thought this was ridiculous and would never happen. And now my kids are like, wait, you had to push a vacuum? You didn't just have a Roomba? What? So it's here. Oh, that wasn't supposed to do that. I think thinking about how do we leverage these LLMs and this generative AI with health records, with ClinPGx. ClinPGx, we are working to connect with health records as well so that the data are all integrated. I think that's the future. And so the last couple things I want to say in my, going over 1 minute, with ClinPGx, no one should panic. Change is hard. You're going to see changes, but they are going to be good things. We're gaining functionality, not losing it. So everything you previously saw with PharmGKB and CPIC and FarmCat, none of it's going away. It's just going to be integrated. If you have feedback, please send it to feedback@PharmGKB. We're building these tools for all of you. And so if you have ideas or feedback, we want to hear it. We are going to be developing more patient and layperson forward tools. I think leveraging large language models, it's going to make that a lot easier. If you want to stay involved and stay up to date, please join the new blog that Terry showed us yesterday, blog.clinpgx.org. There will be a ClinPGx meeting in 2025, so stay tuned for the date and location. Lastly, I just want to acknowledge this conference took a village of people. Terry, I think you're still listening. Thank you so much. And Michelle, Kelly is somewhere. There you are. Thank you so much. We've been meeting like every other week for I don't even know how many months. So it's been a pleasure to work with you all. Ramona and Meg, please thank them on the way out if you haven't already. They have been working like crazy. So much. April and Cindy and Tiffany have been on a bunch of our calls and done stuff as well. We've had a bunch of on-site help, just helping to get people where they needed to be. We had a bunch of volunteers helping to walk people. April and Russica, thank you for running mics and playing our Phil Donahue. Again, I'm showing my age. The AV staff, you all have been amazing. Thank you, thank you, thank you. All the speakers and moderators, thank you so much, especially Paul and Juan Pan. I was so glad that they made it and they stayed all day yesterday. The poster presenters, all of you for participating, and lastly, NHGRI, who supports all of the grants that made this possible. So thank you very much, and we'll see you next year.